Welcome everybody. Today is Thursday the 7th of January 2021, or if you like, the second year in the COVID era. My name is Mark. I'm a cobweb-covered graduate of the London School of Hygiene and Tropical Medicine. I was a mediocre student of infectious disease control. My area of special interest was pandemic-causing viruses, specifically, at that time, HIV. Dusty though I am, I convinced my wife that a COVID-like event was in humanity's imminent future, on the strength of which we moved our family out of London and into the countryside. My guest is Professor Karol Sikora, who has been a consultant oncologist for longer than I have been alive. There are 24 letters after his name. He was the chief of the WHO Cancer Programme. His biography is written in the star bright lights of super high achievement. He has published hundreds of papers and edited or authored 20 books. Professor Sikora is a world authority on the subject of cancer, and he has expressed concerns that the pandemics of myopia and panic that have been the loyal partners to the S2C19 pandemic have caused us to forget about the other causes of morbidity and mortality, the other causes of suffering. Professor, thank you for joining me.
Pleasure.
Now, in May, you spoke with the Unheard YouTube channel and told the interviewer that an extra 50,000 people were expected to suffer and or die from just cancer because their diagnosis had been missed because of the changes that were made to the projects of resource deployment. Now it's January of the following year, we're locked up in lockdown 3.0. Has that 50,000 number changed?
No, it's increasing, and it's not started to increase yet, but it will increase over the next few weeks because it's inevitable that people won't get cancer treatment promptly. And the numbers are quite simple. There are 360,000 new cancer patients a year to be expected, either in 2020 or 2021, it doesn't matter, it's pretty constant. And they're constant throughout the year. So it's not like seasonal respiratory illness, which is a winter related thing. This is constant. If you work it out, the maths are straightforward, 30,000 a month, 1,000 a day, new cancer patients. And all one needs to do to find out what's happening is to go around the pathology laboratories where cancer is diagnosed. Cancer is diagnosed by taking a biopsy, a piece of tissue. It may involve removing the whole cancer. That's called an excision biopsy because you excise the whole tumor and send it to the lab. And that's the only way cancer can really be diagnosed. Sure, blood cancers, leukemias can be diagnosed with a blood test, but most cancers, lung, breast, colon, prostate, are diagnosed by taking a biopsy. And we know what the biopsy rate is. And in March, it began to fall. In April and May of last year, it fell precipitously. And it gradually climbed back up in October when we came out of lockdown 2, I guess. Yeah. So lockdown 1.0 is in your terminology. And then it started falling again from the 1,000 a day that you'd expect when we went into lockdown 2.0. And now it's too early to say. There's always a drop off at Christmas and New Year. So we're now coming out of it. You'd be expecting quite a lot there'll be a backlog of patients from the holiday period coming through. And we're not going to see that. I just know we won't see that. And of course, the problem, Mark, is that cancer's not going away. It's not as though there's some magic thing that the pandemic stops cancer coming because it's, for some reason, it can't deal with pandemics. The cancers are there and they're growing in the patients. They're just not being recognized by the system. And they will come out. They will inevitably patient. And the reasons for it are fairly straightforward, really threefold. One, patient-related, especially older people. They have symptoms, they may have a cough, they may have indigestion, they may have persistent bowel problems. And, you know, who would want to even phone up your GP at a time like this? You want to avoid doctors, you want to avoid hospitals. So patient-related factors. Then there's primary care, GPs. Some are very good, some are very open to phone calls and sorting things out. Others are less good. They've sort of gone into a little Fort Knox type atmosphere and then various surgeries. Certainly actually getting an appointment to actually see the doctor face to face is very difficult. And for some types of cancer, especially if the symptoms are vague, really an examination is sort of essential, and not just an examination, a discussion about the symptoms and seeing how serious they are. I mean, the patients I see all have cancer, so I don't have to diagnose cancer in a sense, but a GP has to do the diagnosis. And then the third thing is the whole hospital system. The biggest challenge today, here we are in the second week in January, and the biggest challenge is cancer surgery. So you have a breast lump, we know it's cancer, how are you going to get it operated? Now, a breast lump's not a bad one because there's no aerosol generated by cutting out a breast lump. But say you had a lump in the throat, that's more dangerous. So these are the issues at stake here, Mark.
We were told that we needed to protect the NHS. And it seemed to me that erecting barriers between people and the National Health Service, their healthcare system, didn't seem like a particularly wise or sensible way to protect the NHS.
Every winter we have problems. I remember the first year I went into hospital after leaving Cambridge and the Ivory Tower, and then you go into the hospital, and it was the flu pandemic of 1969, and it was a relatively minor pandemic, but it was chaos. Operations were cancelled and all routine procedures, but it was only for a month or two. People were on ventilators on the open wards, and it was a very good experience for me as a first year clinical student, sort of working out how to run ventilators. So you're given hands-on experience by definition because there weren't enough doctors. And every winter we have these crises, and it's got worse over the last decade. And the reason it's got worse is that people have got older and the average age of the population is older. Now, the thing that strikes me about COVID is that the average age of death is 82.4. Now, that's very different from the average age of death of cancer or heart disease or stroke, which is on the whole much younger, especially heart attacks can be much younger. So you're sacrificing, by putting all the effort into COVID, you're sacrificing a whole load of other things. Now, in the first lockdown, that wasn't discussed at all. Now it's more discussed, and serious attempts have been made by the NHS to maintain cancer services, but it is difficult. And of course, it's not just the NHS, it's up to patients themselves coming forward, and indeed GPs who, general practice is a strange thing. It's not really in the NHS, it's their private businesses operating on behalf of the NHS. And they're not consistent in their policies and how they operate. So it is much more difficult. So we're in a very difficult situation going forward now. And it's a matter of how you prioritize different aspects of healthcare. And at the end of the day, when you look at things, there are certain things that always have low priority in healthcare systems. Mental health being a great example. Difficult to measure the outcomes. You know, that there are people that are paranoid schizophrenics that go wielding axes. These are extremely rare. Most mental health issues are relatively low level, depression, misery, and bipolar disorders. And the trouble for the NHS is it sweeps those aside because of COVID. It doesn't have time to deal with them. It says we've got a higher priority. Well, why is it a higher priority? Certain things have to come up the chain, if you like, of priorities. You can't let COVID dominate the whole thing.
Well, I mean, there was a time in the past when, cancer would have been the big C, and, receiving a cancer diagnosis would have been the most frightening thing that a person could experience. Why do you think it is that people are much more frightened about COVID-19, or have been convinced to be frightened of COVID-19 in the way that they have, to the detriment of, I would say, everybody, and our ability to respond to conditions of normality, which it seems to me we are selecting for inflations acutely and over a longer period of time?
I mean, you hit the nail on the head there, Mark, with the fear factor. That's been installed in people to be totally frightened of this disease in a way that it's really quite surprising when you look at the statistics in terms of what happens every year with respiratory illnesses in older people. Every year, a lot of people die. And we think nothing of it, and we just accept that in society. Sure, more people have died this year and last year, obviously, but it's not, it tends to be the elderly. And sure, there are children that die, there are the adolescents, but these are very rare from COVID. With other diseases, it's much more constant. The pattern of cancer across the age groups is constant year on year. And sure, children and babies even get cancer, but it's extremely rare, thank goodness. Whereas as you go through life, cancer becomes more and more predominant when people reach the 6th decade and the 7th decade. And then ironically, it falls off in the 8th decade for some reason and it becomes less aggressive. So the problem we've got a health system, and it doesn't matter how you pay for it, whether it's NHS-like with a tax system or an insurance system, or even a sort of American type free market. The problem is someone's got to prioritize what's important. And COVID has come to the top of the pile at the moment. And this is dangerous because other illnesses will cause, if we ignore other illnesses, we do so at our peril because these illnesses will cause more deaths. And the other problem of looking at it is this business of life years lost, and we don't tend to do that.
Yeah, those adjustments of quality and disability. I mean, I suppose the appetite to say that one life is more valuable than another, the appetite for that maybe isn't there, or these are conversations that people are just not willing to have because the sensitivity to that is simply too great. But maybe this is a question that you wouldn't want to answer. I know that other people who I've asked this question of, friends, relatives, haven't wanted to answer it. Is it reasonable to say that a life lost at the age of 5 is more valuable than a life lost at the average age of 82? Or are you just going to end up in impossibly hot water?
No, I think you can do that. We don't like doing it. And, you know, the NHS being a sort of equitable organization steers well clear of ageism in. So say you have a very expensive cancer drug. Let's take that example. And there are some that are over £120,000 a year to give. So you've got this drug and you have two choices. You've got two patients. You've only got one shot of £120,000. It's the last bit on your budget for the year, so you can give it to one patient. You've got a 30-year-old woman who's got 2 babies and she's you know, got a life to look forward to, and you've got an 80-year-old smoker who is coughing away. He's got chronic respiratory disease. His prognosis anyway is 2 years just from his general condition. Who would you give it to? I mean, the rational human being would give it to the lady. Every time I use that example outside the medical fraternity, we all understand that as doctors, but if you use it outside, you're being called judgmental, and how can you do that? And then you can add all sorts of scenarios, you know, that the 80-year-old man is in prison for multiple murders and rapes, for example.
Yeah.
And so he becomes devalued in society. And you can add to the woman, she could be a brilliant concert pianist, for example, totally irrelevant to what you're discussing in reality. But you're moving these things along. And so there's no good way of comparing a human life. And that is our problem. And you know, we have it all the time in oncology.
Because it seems to me that COVID has become so dominant that we're not prepared to have that conversation about adjustment or life years lost, about anything at all. So it's COVID versus everything else, and COVID is winning. So it's not just making the choice between cancer patients, it's allocating all resources to COVID so that people, I mean, suicide is being selected for, inflations in all forms of mental illness are being selected for, as are physical abuse, marital failure. Can it be changed? Do you think there is an appetite for it being changed so that maybe these other conditions will actually, the damage that is being done to our ability to respond to these conditions of normality can actually be changed? Is there an appetite for that, or do you think we're just going to get more and more of COVID?
It critically depends how long this goes on for. So, you know, we've been in this lockdown for a week or so, and there's no doubt that if it goes on for 2 or 3 weeks, a short, sharp blip, then everything you can put most illnesses on hold for 2 or 3 weeks. Most cancers, there won't be much difference after a few weeks.
Mm-hmm.
If you go on for a few months, there will be differences and people will die of other things. The only illness where you do have problems, and the NHS has, in all fairness, tried to protect it, are people having heart attacks, that they're actually keeping the cardiology services going so that they can have stents and surgery, urgent surgery if necessary. So that's been left in place, although it's not nearly as efficient as it was outside lockdown for a variety of reasons. And as systems get, as the whole healthcare pressure gets higher for resource, even that will go in the end. And so it's all to do with the duration. A few days, no problem. A few weeks, beginning to have problems. A few months, serious problems. And what worries me about lockdown 3.0 is there is no exit strategy. There is nothing written. Okay, the vaccine, the light at the end of the tunnel, you see it in all the mainstream media.
Yeah.
The problem with the vaccine is we don't know how long the immunity is going to last, because it's not been around long enough to do that. And we don't know if mutations can break through. So, putting everything onto the vaccine is not a safe way forward.
They have accelerated the production of this vaccine. They can't possibly know what the mid or long-term effects are. And people are being told that the gold standards that were can be redefined and that's okay. Does that worry you at all?
I mean, what else could you do, Mark? That's the problem. If you look at the politicians, they just reflect what the advice they're given by the scientists. And what can you say? I mean, should we not vaccinate people? Should we just keep the clinical trials of 40 or 50,000 people? Should we just keep those running for a lot longer before we start going? It seems reasonable to try to give it, but I think the idea that this is some sort of panacea, that it's a light at the end of the tunnel, it may not turn out like that. And what's encouraging so far is the side effects seem pretty minimal. There's been 1 or 2 serious adverse effects, but they're on the whole relatively minimal, considering that we're talking about millions of people being vaccinated around the world. And so with all the vaccines, there's been nothing serious. Yeah. There were some in the trials. There were a couple of transverse myelitis, spinal cord inflammation, which is serious. But there's nothing more has come. But the biggest question is, how long is immunity there for? And secondly, is this mutation? Mutation can get round the immune attack by immunization. And the theoretical work that's being done, where you look at the spike proteins, the things that children draw on the virus, and we know the amino acid structure, the building blocks, the protein building blocks, and you can look for the mutations which are moving around. And we've heard about the South African variant and the UK, the Kent variant. So you've got these ones. Now, if there are more that can evade where the antibodies and T cells bind to it, in theory, they could evade the whole thing. Now, the only way to play with it now, until you wait and see what happens for real, is to do theoretical examination of what sort of mutations would break through and look for them out there. And the theoretical construction, to deliberately try and see how you design a virus that could break through. Is it possible to design one? If it isn't possible, great. But I suspect it is possible. And I suspect mutants will inevitably emerge. And then what do you do? The panic about South Africa, and if you remember 2 weeks ago, they stopped all entry to the UK from South Africa, which is a drastic thing to do. Even for people that were British coming home, it was stopped, which is unusual. Normally citizens of a country allow their own citizens to free travel, free passage into the country. Sure. Was because it was thought that maybe this one is a mutation that would break through the vaccine. So that is the problem. And no one talks about this because it's like it removes the light at the end of the tunnel and suddenly you're back into darkness, and you don't want to hear that. And it's all part of this lack of any exit strategy. Then the other thing, I guess, is this whole business of herd immunity. It's like a dirty word,
Yes.
all the conspirators, and myself included, that talk about herd immunity, Sunetra Gupta, Carl Hennig, and all the other bad guys at the moment that we talked about. And that means millions will die because of herd immunity. But what's the alternative? And the alternative is to just continue this miserable life for the whole of society. And of course, the thing about lockdowns, it affects poor people a lot more than it affects rich people. Absolutely. And similarly, people that are professionals in jobs, healthcare workers, public sector workers all have pensions, council workers, they have pensions, they have, middle management have a comfortable lifestyle. And so they're the ones making decisions. And for them, it doesn't matter. I mean, a lot of people are working from home. The other thing, Mark, people with with jobs that involve actually having to go to work. There are some people that are on relatively low salaries, minimum wage type, £8.50, £10 an hour type salary, that have to go to work. If they don't turn up, they don't get paid. And an Uber driver, for example, that's the basis on which this works. And so basically, these people have to do it to stay in the game. Otherwise, they'll have no income at all. And so they're really adversely affected compared to, say, a school teacher or a health professional who is less adversely affected by it all and has a bigger support group and all the rest of it. I mean, most educated people in middle income jobs have support groups around them, and they go forward. Whereas a lot of people in the gig economy have no support group whatsoever. Even if they go to work, there's no support group. It's just, there you go. And, it always has fascinated me, public transport at the different times. Living out of London, I take a train in. If I go in at 6, it's a totally different customer base on the train than if I go in at 8 or at 10. This was before lockdown. It was just totally. Now, there's nobody on the train, so you get a train to yourself, which is nice but worrying. It's scary.
Yes, it's very scary. It is very scary what's been done to, yes, the cities and our ability to be productive, and also to our willingness to be productive, and the changes that appear to, as we're told, are our new normal and shall be with us forever. You've been very generous with your time, so our half an hour has come to an end, but if you wouldn't mind, just to sum up, what do you think is going to happen over the next few weeks and months?
My prediction is it's going to take the current politicians some time to get around to the fact they've got to have an exit strategy. We can't go on like this, and we can't come out and then go back into lockdown 4.0, and that would not be a good way forward.
Let that not happen.
So I think once a certain percentage of people have been vaccinated, they'll say that's it, and we can come out. But I suspect it won't be like that. There'll be still a lot of infection around, and it won't just magically disappear by Easter or by summer. And we're just going to have to learn to live with it and put up with it. And there will be deaths due to the coronaviruses, but they'll just be accepted as part of life.
Yes.
And that's what probably we've got to get to. And the cynics, the people that have said, look, we've just got to go for immunity in the population and the variants and everything, and just people have to take their chances as we go through. And that's how we'll end up, just basically not forgetting about it, but recognizing it's there and getting on with our lives without worrying about it. And that's going to be the challenge. Sure. And the people who are going to suffer most are your generation and the generation below you, especially the students that are coming up of college, no jobs, no prospects, very difficult situation, everyone frightened, and no money. And the country is going to be bankrupt, there's no doubt, as all countries will be.
As you can see, a career in continuity is probably not in my future. Karol and I went on to talk about the impact the pandemic has made upon our families, and it wouldn't really be appropriate to include any of that. But as we were talking, I thanked him very much for his time, which will be missed as a consequence. So I'll thank him now. It was incredibly kind of him to give me the time that he did. Very generous, and he was an absolutely superb interviewee. And I hope you enjoyed it.